Great, this presentation is going to cover abdominal and genitourinary trauma. Abdominal trauma can be very challenging because there are so many organs located here. Because of this, the patient's presentation can vary widely, and some injuries can quickly become life-threatening. Abdominal organs are very vulnerable to trauma because the abdomen lacks any protective structures from the skeletal system. For example, in the chest, a lot of our organs there are protected from the rib cage. But as we can see with the abdomen, it's kind of open for injury. Trauma to the abdomen is typically blunt or penetrating, and this can range from minor injuries or injuries that only involve one organ to very complex life-threatening injuries that can involve multiple organs or organ systems. There are also outside factors that can help decrease or increase damage. For example, an empty bladder is less likely to be damaged by blunt trauma than a full bladder because the bladder muscle is so stretched. The same can apply to the abdomen. Having toned abdomen muscles provides a little bit more protection and may decrease risk of injury. The most common solid organ injury for penetrating trauma is going to be the liver, but for blunt trauma would actually be the spleen. The liver is more commonly injured in penetrating trauma because it's very large and vascular, and although some of it is protected by the rib cage, the majority is not, and it stretches mostly from the right side, but it does stretch across to the left side. The most common hollow organ that's injured is the small intestine, and this, just like the liver, is based on its size, and it covers a very large area. If abdominal injuries are suspected, your assessment and intervention should be performed quickly but cautiously. The assessment can be difficult because you cannot see internal structures, and you are going to rely on knowing the location of the abdominal organs. You also should be able to tell from their complaints of pain what area they're referring to, and knowing what organs lie under that. We should also do a very thorough exam of the abdomen, including palpation. The patient may have sustained injuries to adjacent organs, which can further complicate narrowing down the source of pain. Ultimately, these patients will require advanced imaging such as CT scans and surgical interventions. Trauma to the genitourinary systems are also most likely to be caused by blunt or penetrating trauma. Most of these injuries happen to the kidneys, which lie in the retroperitoneal space just below the ribcage. This can be serious because the kidneys are also a very vascular organ. Genitourinary trauma should be assumed whenever there's an injury to the lower ribs, the pelvis, or upper legs. Keep in mind that you may be the only source of information for the emergency department staff or ER physician, or even the surgeons. So it's really important that you understand the events leading up to the injury or the mechanism of injury that caused the trauma. You must be a good investigator and be able to scan your scene and identify the mechanism of trauma and what underlying injuries may be associated with that. This will help you have a high index of suspicion for injuries that you may not be able to see. For example, with this truck accident, we have a truck versus a tree. It would be really important to tell the surgeon or the ER physician how far this tree actually goes into the side of the truck, because that's going to indicate a really high mechanism of injury. Also, that the tree was on the left side of the truck, and the driver would have more left-sided injury, so we'd be worried about a spleen injury in this case. The abdominal cavity extends from the diaphragm down to the pelvic brim. There are solid and hollow organs. Hollow organs are the organs involving the digestive tract, such as the stomach, small and large intestine. Solid organs are more vascular and dense, and they're more prone to bleeding. These include the liver and spleen. There are also retroperitoneal space in the posterior portion of the abdomen, and that contains the kidneys, which is another solid organ, along with some great vessels such as branches of the aorta and inferior vena cava, the bladder, a portion of the large intestine, which would be the rectum. The quadrant system is used to help guide our assessment and documentation, and also help us pinpoint a source of injury or pain. The area around the belly button is called the periumbilical area. The right upper quadrant contains the gallbladder, the pancreas, and most of the liver. The left upper quadrant contains a large portion of the stomach and also contains the spleen. The right lower quadrant contains the appendix, portions of the large and small intestine, and the left lower quadrant contains the large and small intestine as well. The peritoneal cavity is the main abdominal cavity. Its top border is the diaphragm, and the lower border is the pelvic brim. The retroperitoneal cavity is posterior and inferior to the peritoneal cavity and contains the kidneys, the adrenals, some great vessels which are not shown here, the rectum, and the bladder. The peritoneum is actually the lining of the peritoneal cavity. So we have two peritoneums. We have the visceral peritoneum, which is highlighted in red. And that's the lining of the cavity that borders the organs. So you can see around all the organs, we have that red lining. The parietal peritoneum lines the cavity wall, and this is highlighted in blue. So anytime we have that peritoneum lining the actual cavity wall, that's the parietal peritoneum. The mesentery is an organ that attaches to the intestines and the abdominal wall, and it's formed by a double fold of peritoneum. It helps suspend the abdominal organs and holds them in place, and it also allows blood vessels, lymphatics, and nerves to supply the intestines. And in this picture, the mesentery is highlighted in purple. Solid organs are more dense and vascular. They are easily crushed by blunt trauma to the unprotected abdomen. The spleen is actually the most commonly injured as far as blunt trauma and solid organs go. The liver is the most commonly injured solid organ in penetrating trauma, mainly because of its large size. Both organs have a very rich blood supply and can cause major internal bleeding. If the patient has unexplained symptoms of shock, consider trauma to these organs. Hollow organs are more resilient to blunt trauma since they're not filled with blood and they have a little more room to give. However, the more full the organ is, the more likely it is to be injured. So having a full stomach allows less give when it's hit with a blunt object. And if a hollow organ is completely full, it's at risk for bursting. When a hollow organ bursts, digested substances are released into the peritoneal cavity, causing peritonitis, which remember is from medical, is the inflammation of the lining in the abdomen. So think back to 134. This can quickly turn into sepsis and then death. The most commonly injured hollow organ is going to be the small intestine, again because of its big size. There are two types of peritonitis, chemical and bacterial. Chemical peritonitis can be caused by trauma and has a sudden or acute onset. This is caused by the spillage of hollow organ contents into the abdomen after an organ ruptures. Bacterial peritonitis takes several hours to set in and is caused by a bacterial infection. This is either caused by an infection traveling through the blood or lymph, which is a primary infection, or from the spilled contents of abdominal organs, which is a secondary infection. No matter the cause, peritonitis is serious and life-threatening. You must be able to have a high index of suspicion based on the MOI your patient was exposed to. Symptoms of chemical peritonitis include diffuse abdominal pain with a rigid board-like abdomen on palpation. Blunt trauma has many causes, could be something as simple as a fall or a strike to the abdomen, to something very serious like a car accident. Penetrating trauma most commonly occurs from stabbings or gunshot wounds, and penetrating and blunt trauma may also occur in combination. Signs of significant trauma include hypotension, major chest injury, or major pelvic fracture. So any of those three things, we should be thinking abdominal trauma. Unrecognized abdominal trauma is the leading cause of death in trauma patients. And again, it's because we can't see those internal organs, so sometimes it goes unnoticed. Blunt abdominal trauma may also cause crush injuries, and this occurs when there's a rapid deceleration or compression to the closed abdominal cavity. Sometimes soft tissue damage on the outside can lead us to clues. Like here in this picture, we have the bruising over the abdomen, giving us soft tissue damage that tells us that there's some major trauma below. And this is from a seatbelt. Even a direct blow to the abdomen may cause crush injuries and can injure solid organs or cause hollow organs to rupture. Shearing happens when internal organs continue to move forward in motion after rapid deceleration, like in a car accident or fall. And this causes the organs inside the abdomen and their vascular structures that are attaching them to the aorta, the inferior vena cava, to stretch and tear, especially at their points of attachment. Some organs that are really prone to shearing include the liver, especially because the liver has a ligament where it attaches, kidneys, the small and large intestines, and the spleen. Crushing is caused by that external factor and occurs when the abdominal contents are crushed between the anterior abdominal wall and the spinal column. So it looks like this patient here may have been run over because we can kind of see tire tracks in their injury pattern. Solid organs are at greatest risk during crushing, and we worry about the kidneys in the back, the liver, and the spleen. Some things that can cause these crushing forces are dashboards in car accidents, the front of the car in some type of pedestrian, or the pedestrian getting run over, falling objects that may fall on a patient, and possibly steering wheels, but that would more affect the chest. Penetrating trauma lacerates or cuts the skin, and the penetrating object will then enter the abdominal cavity. More commonly with our penetrating trauma is going to be stab wounds or gunshot wounds. This creates an open abdominal injury, which can lead to infection, but more importantly can lead to some bleeding and some clues that we can see where that injury pattern is going to lie and what organs may be affected. Bullets can travel pretty deep into the abdominal cavity and can cause cavitation, which causes even more damage. The bullets can also bounce off bone or other organs and hit multiple spots. So the extent of injury depends on the size of the weapon, whether it's especially the size of the knife that was used in a stabbing, or the type of bullet or type of caliber bullet or the type of weapon. We want to try to determine the pathway so we can assess what organs may be injured or damaged, but keep in mind the spine may also be involved, especially in gunshot wounds where we may not be able to see that pathway if that bullet's moved around inside the cavity. So anytime I have an abdominal patient or a shooting patient that was hit in the abdominal region, I always consider C-spine when I'm packaging this patient up because I don't know if that bullet bounced around inside the abdominal cavity, could have possibly hit the spinal cord. Also, we don't want to label things entrance and exit wounds and that's more of a court documentation thing. When you do go to court, you don't want to be put on the stand and have your report say, well, the patient must have been shot from this direction because you labeled this an entrance wound and you labeled this an exit wound. We could also miss gunshots that way. If we label an entrance and exit wound, could actually be two entrance wounds. So we just want to stay away from labeling it that way, and we just want to mark them as wounds. When we get gunshot wounds to the abdomen, the most commonly involved organs are going to be the small bowel. Again, because its size and its location, it kind of covers the whole front of the abdomen. It could involve the liver, again, because of its size, and we would worry about a lot of bleeding there, or any vascular structures as well. So we have the inferior vena cava and the aorta. With penetrating trauma, it's the same thing. It's going to be the liver and the small bowel that we're going to be worried about, but we're also going to throw in the diaphragm there. Seatbelts can be a really common cause of compression injuries, so something we want to think about in our car accident patients, and we're going to actually look at the belly to look for those seatbelt signs or that bruising across the abdomen. If we do see one of those seatbelt signs, it is a cause to activate a trauma alert at your local facility because it means there's probably some pretty severe compression trauma in that lower abdomen. The correct way to wear a seatbelt is down here where we put the seatbelt below those iliac spines, so it kind of holds the seatbelt in place. But we do get a lot of lap belts maybe going a little higher. I probably see this pretty common, where it's kind of going over the belly button, and people do that so they're more comfortable while they're driving. internal hemorrhages can be really difficult to pick up on because we don't really see any external blood loss. So it's difficult also to estimate how much blood loss has happened when we can't see it. You're kind of stuck being dependent on assessing the patient for signs and symptoms of hemorrhage or hypovolemic shock. And that's really going to be dependent on the rate of blood loss, how fast they're losing blood, and how much blood they've actually lost. So we always kind of want to be constantly reassessing our patient for shock because we can switch from that compensated to decompensated shock pretty quickly. Now we can see some signs that would point us to an internal hemorrhage. We can see how this belly is kind of distended outwards. So that's one of the first signs that you'll see if you have a major internal hemorrhage. I had a patient, he was a young male patient who was in a car accident, and he had sheared one of his arteries in his abdomen, one of the smaller arteries. I can't remember which one it was, but obviously he had a lot of bleeding very fast. And by the time that Life Flight had landed to pick up this patient, he had looked pregnant. He looked about 8 months pregnant because there was so much blood in his belly that it had extended outward so much. We can also look for this bruising, but sometimes that takes some time to show up, so it's not something we may see immediately. If we do get an organ that ruptures and their contents spill into the abdominal cavity, that patient's going to have a pretty irritated belly and abdomen, so they're probably going to be complaining of a ton of pain. And that irritation will happen on the surrounding tissues. The fascia that covers the tissue is innervated by nerve endings. So that tissue is going to become inflamed and very irritated. So they should be able to feel that pain pretty instantly. And if it's just very localized, if it was a very small rupture and we only had a little bit of contents leak out, we would be able to localize it very well. But if it was a pretty significant rupture and those contents are going to kind of leak everywhere on the peritoneal cavity, their entire abdomen will be feeling irritated and painful. So we may not be able to localize that point of injury. As far as our scene size up, remember that your scene safety is priority. So there's a few things we need to think about with trauma patients, especially abdominal trauma. One of the common causes of abdominal trauma we talked about are going to be gunshot wounds and stabbings or assault, especially if we had blunt force to the abdomen. So make sure your scene is safe. These situations can be very dangerous for a paramedic. We often don't have protection. So typically with these types of calls, we want PD to clear our scene prior to us even coming on scene. So make sure your scene is safe and make sure that your dispatcher, you are communicating very well with your law enforcement to make sure it's okay to come towards the patient. Same things go with car accidents. We could have fluids leaking from the car, like gas leaking, which could be, a huge hazard for us if that were to ignite. The car could still be running, the motor could still be running. There's a lot of moving factors in there. We want to make sure that the scene is safe prior to just walking up there and maybe opening up the car door and getting in the car to hold C-spine or something like that. When we're doing our primary assessment, that's just like any other primary assessment in a trauma patient. So airway, is their airway open? Are they breathing? Do we have equal chest rise and fall? How does their skin look? How's their circulation? D is going to be disability. So what is their mental status? What is their AFPU score? And then E is exposure. And exposure has two things. Exposure is one, is it cold outside? Is it hot outside? Is there some kind of environmental exposure? But also we want to expose our patients so we can get a good view of all their injuries. Keep in mind, if there is a life threat bleed, we are going to switch that to CABDE, or if there's a cardiac arrest. So the only time we put circulation before A is if there's a life-threatening bleed or if the patient is in cardiac arrest. When we're looking at our general impression, we want to look at how the patient is presenting. They could be laying in the fetal position, which is common with abdominal pains. They could be guarding, which is kind of tensing those abdominal muscles because of they're in pain. So those are things that we want to look out for. When we're looking at airway and breathing, it's going to be like any other assessment. So airway, one thing we do want to check for is any vomit or secretions in the airway. We want to make sure the airway is open. If not, we want to put in some type of airway adjunct. And then we're going to assess breathing, and things we should do for breathing is looking at the rate and quality. We should be visualizing that chest, looking for equal chest rise and fall. And if we have a stethoscope handy, we should really be checking lung sounds quick to make sure we have lung sounds on both sides. We do want to maintain that pulse ox above 94%. So we're going to apply supplemental oxygen, whatever we need to apply to maintain that pulse ox above 94%. The circulation, again, it's going to be the same as any of our other assessments, but we want to look at their skin. Are they pink, warm, and dry, or are they pale? Are they cold? Are they diaphoretic? We want to assess the pulse, and typically I just head for the radial. I know if they have a good radial, they have a systolic that's pretty decent, probably around 90. So we want to assess the pulse for rate and quality. And we could do a quick check of the cap refill time. Keep in mind with these abdominal trauma patients, your patient could have a hemorrhage and we're just not able to see it because it's internal. So their circulation might be tanking and they might have some of these symptoms like weak thready pulse and pale, cool, diaphoretic skin, even though we can't visualize any bleeding. For our transport decision, we should really have a short on-scene time for abdominal injuries because ultimately this patient's going to need surgical intervention and they're going to need to be taken to a trauma center ultimately where they will have surgery available for them. So keep that in mind and just know what your local protocol is. For example, for me, I only really have one choice of hospital. So I'm either going to be flying this patient if weather allows that, or I'm going to be taking them to the nearest hospital where they can be stabilized and then transferred to a trauma center. But if I work somewhere like Cleveland, I have a lot of different hospitals to choose from. So going to a level 1 trauma center when I have that option would probably be the best option. Your history taking is just going to be like any other history, but we're going to throw some trauma stuff in there. So you get your sample history, which is pretty normal. But for example, if we have a car accident, some things we want to put in our history and definitely in our narrative. I always put the type of vehicle. I never put like the manufacturer or model of the vehicle, but I always put like a 4-door sedan or 2-door sedan, pickup truck, that type of description. I never really include the speed of vehicle or speed of travel because I wasn't there, so I don't really know. You can put that this was a fast-paced road. Speed limit of 60, would kind of trigger you to think, wow, this is a really fast road. Maybe they were going at a high rate of speed as opposed to like 25-mile-an-hour road where they're probably going a lot slower. You do want to put how the vehicles collided. However, it's important to remain very, very objective. So I don't always, when I say how vehicles collided, I don't put in my report, this vehicle hit this vehicle, or, because you don't want to implicate anyone in the crash. You're not a police officer. You're more there just to kind of document the scene. So I'll put where the damage is on the vehicle. So if, I have a car that has heavy front end damage, I'm just going to put that heavy front end damage on this car. There's also a pickup truck that had heavy driver's side damage. So they can put that together and figure out, oh, that pickup truck was T-boned. But I'm not really saying how it happened because, again, I'm not leading an investigation. I'm just trying to document how the scene looks. Other information we want to include, did the patient, were they wearing a seatbelt? If they weren't wearing a seatbelt when you got there, did they say they were wearing a seatbelt? What airbags deployed, if at all the airbags deployed, and then also what their position was in the vehicle. So if we head back to this scene, how I would document this in my report and to the ER physician, if I were, say, taking care of the driver, I would say this was a pickup truck with heavy driver's side damage, very heavy driver's side damage. Patient was driving the vehicle. He was wearing a seatbelt at the time of impact, and the side curtain airbags as well as the front airbag had deployed. And again, I can't see the airbags in this picture, but I'm just assuming that that's what would have happened. So that's how I would document that. Now, when it comes to assault, again, you want to be very objective. You don't want to implicate anybody. You're not leading an investigation, but some really important things that you want to document, especially for the ED staff. If it was a stabbing, we want to get some kind of idea what type of knife it was. If the knife's not on scene, you can ask the patient for a description. We mainly want to know how long that knife was. So we can kind of estimate how deep that knife went into the patient's body, which could affect what organs were affected. if the patient does know what angle of entry is, so we can kind of figure out the pathway of the injury. And then most importantly, we want to count the number of wounds. So if we find, say, 7 wounds on the patient's abdomen, we'll document that as finding 7 lacerations on the patient's abdomen, consistent with a stab wound. With gunshots, we need to be very careful also how we document these. These injuries are likely to become a court case, so it's something that you could be subpoenaed in for as a witness. So you want to remain very, very objective. So if we do know what type of gun it is because the gun's there, or there's knowledge of that, we can put that in our report. We will report how many times the patient states they were shot and how far away that the shots came from. And again, that's all information that hopefully our patient can give us, but if our patient's unresponsive, we're going to have to leave that out because we don't really know. You want to put the number of wounds. You don't necessarily want to label them as entrance or exit wounds. So we commonly see that in reports because the exit wounds will be larger because of cavitation, that people will label them as entrance and exit wounds. But really, when you go to court and you're a witness, you don't want them calling you out in the stand and saying, you labeled this an entrance wound, you labeled this an exit wound, so it had to be that the patient was shot from this angle. It's going to put a lot of responsibility on you, so really just label them as wounds. Now, you should be thinking, is this an entrance or exit wound? And we can kind of determine the pathway of injury, so we can kind of guess what organs could be injured, especially when we're thinking about spinal cord injuries. Another thing we're doing when we're looking at breathing, we're looking for that equal chest rise and fall, equal chest expansion, but we also want to listen to breath sounds. If we haven't already, we should be doing that now in our secondary assessment. Diaphragm ruptures are common with stab wounds, so it is something that we want to listen for. And with a diaphragm rupture, that would leak abdominal contents into the chest cavity. And we talked a little bit about this in chest trauma. You would actually possibly hear some bowel sounds when you were trying to listen for breath sounds. So obviously that would kind of be a light bulb going off in our head, like, I shouldn't have this here. And that's a very, very serious sign of injury, and that patient's most likely going to benefit from positive pressure ventilation. So we should definitely be listening to lung sounds at this point if we have not already. When we're assessing the abdomen itself, doing our visual assessment and our palpation, we should be assessing for rigidity, distension, any rebound tenderness, any types of abrasions or contusions over the abdomen, or any evisceration, which would be organs hanging outside the abdomen, which would be pretty obvious to see. When I look at this patient here, I see some abrasions here, but I also see some rigidity and maybe a little distension here in the abdomen wall, like maybe he had some type of compression or crushing injury. But make sure you are inspecting the abdomen by looking and then also palpating. So we do want to palpate the entire abdomen, and we do this by quadrants. And we do want to start with the quadrant furthest away from the injury. So if I have an injury to the right upper quadrant, I'm going to start with the left lower quadrant, the furthest away, and then move my way towards that injury. Because if I palpate that injured spot first, it's just going to elicit a lot of pain, a lot of irritation, and then they may have some pain everywhere after that. This is not something that's easily accessible in EMS, but if we had the opportunity or if the patient reported to us, we do want to know if there's any bleeding in the urine, because it could indicate some type of urinary tract damage. So that's really, really important to note. If we do have blood in the urine, probably be something that the patient self-reports. We can, if we are patient's unresponsive and we are exposing the patient, we may see some bloody urine in their clothes or something along that line, which I've seen in some major traumas, and that should indicate to us that there's some type of possible bladder damage. So there are some new things that are becoming available to us. I don't see them out really deployed yet, but I see some of this going on in the ERs. So one of the coolest things I think is a FAST exam. And a FAST exam is a focused assessment with sonography for trauma. And that's basically an ultrasound. It's a quick ultrasound of the belly And I'm really bad at reading these because I haven't been formally trained in this, but our ER docs did them a lot on all the traumas that came in, and they would do a quick exam of the major organs and look for bleeding. So this is an ultrasound of a liver, and any bleeding would be black. So we can see here there's a liver laceration with some bleeding. So it's like a really quick way to pick up on some internal organ damage, whereas before we would have to wait until we sent the patient to a CT scan. Another thing is telemedicine. This is helping us, and especially in some of our rural hospitals. I haven't seen it on squads yet. I have seen a few squads with fast exams, especially like our mobile ICUs and stuff. They may have a ultrasound able to do fast exams, or if we do have a critical care or our metro ground units, they all have the capability of doing fast exams. For telemedicine, this is actually talking to a physician somewhere else, probably a trauma physician at a level 1 place, or maybe even the surgeon that will be taking care of this patient, and kind of doing that phone conversation, which is usually like a FaceTime type call, so they can see the patient and they can get some diagnostic data from the EMS scene. So those are things that I could see becoming more popular because of the technologies that are becoming more and more available. For any abdominal, just like with chest pain, we should be doing our OPQRST. So onset, provocation, what makes it worse, quality, radiation, if it radiates anywhere, which we do get with some abdominal organs, especially the spleen, we get that left shoulder pain that's called Kerr's sign. Severity of the pain and timing. When I'm talking about severity, I ask the patient, 0 being no pain to 10 being the worst pain you've ever felt in your life. How do you rate this pain? So if this is the worst injury they've ever had, I would expect them to say 10. So something to keep in mind, but that's how we kind of grade that 0 to 10 scale. We have somatic type pain. Somatic pain comes from the skin, muscle, joints, ligaments, and tendons. These are organs that have direct nerve innervation, and this is a very sharp and localized type pain. So it's easy to localize, easy to tell where the injury is coming from. And then we have visceral pain, which is a little more difficult to localize because this is our organ pain. So a lot of times it's a really deep, aching, cramping pain that might not be easy to localize at all. Our reassessment includes going back over and repeating that primary assessment. We definitely want to make sure we're reassessing our ABCs. We can ask more detailed questions, look at the abdomen in a more detail, looking for that contour of the abdomen, whether they have nausea, vomiting. Maybe we might see some ecchymosis or bruising starting to form where we didn't see before. We definitely want to reassess for tenderness, guarding, rigidity, and any localized pain. We could have more distension than maybe we had before because bleeding's happening. So we just want to go ahead and reassess everything. And also, if we've done any interventions, we want to reassess at that time how our interventions are holding up. As far as our emergency medical care, once we do our ABCDE, so make sure we are exposing the patient, looking for other injuries. That does include the back. We should start IVs for trauma patients. We typically like to get a large bore IV, so I try to get an 18 gauge. And if I can get an 18 gauge in each arm, especially if I know if the patient's going to surgery, that's great. If you're only going to do one IV, we may even possibly try to push for that 16 gauge. We want to apply any dressings if necessary. So this is, when we go back and do our secondary assessment, we can go back and dress all of those small distracting injuries that maybe we didn't address before. So any abrasions we can kind of clean and put dry sterile dressings over. Any small lacerations, things like that, we can go ahead and cover with dressings. Also for our treatment, make sure we're putting on a cardiac monitor, monitoring that pulse rate, especially for signs of shock. Pulse oximetry, keep that pulse ox above 94%. As far as our fluid boluses, we're establishing IVs. We want to be prepared to give fluids in case this patient does have a hemorrhage and they do start to go into that decompensated shock. But we're really going to base it off that blood pressure. We want that blood pressure to be about 90 systolic or a little bit higher. But we're not just going to go ahead and preemptively load this patient up with fluid just because they're a trauma patient. Remember that if we have those little clots forming inside, tamponating off some bleeding, we don't want to disturb those or push those out by upping their pressure. So we really just want them to be around that 90 to 100 systolic. So if we have a trauma patient that's sitting at 120 over 70, we're not going to push any fluids at all. Just be prepared to push fluids in the event that their blood pressure does go hypotensive. And if they do, we're going to give that 20 cc's per kilogram, try to maintain that BP above 90 systolic. And then we're going to transport that patient to a hospital, preferably a trauma center. As far as pain medication, it's really going to be dependent on your protocol. Currently with our regional protocols and our UH protocols, we are giving pain medication as long as it's not contraindicated for our abdominal trauma patients. The reason that it's kind of a debate or controversial is because a lot of physicians want to be able to assess that abdominal pain because we can't see all those organs. We're really kind of dependent on our assessment of that patient and guessing what's kind of wrong with that patient. So when we give them our pain medication, the doc may not be able to do a very good assessment. However, that's really changing, and now in our protocol, yes, we are giving pain medication for this patient, and our pain medication right now that we use is going to be fentanyl. So fentanyl is great in that it doesn't cause so much vasodilation, so we're not getting that decrease in blood pressure, that hypotension that we see with Dilaudid and morphine. So it's really, really great for trauma patients. We give anywhere from, our dose ranges from 25 micrograms to 100 micrograms. The way I typically do it, I usually never give more than 50 in one dose. And if I have a very small person, like an elderly person or someone who's just very tiny in stature, I start off with 25 micrograms. I draw up 50, I'll push 25. See how they act in like 1 to 2 minutes, make sure they're not going to, get that decreased respiratory drive or some nausea, vomiting, and then I'll go ahead and push that other 25. So I'm just kind of splitting it up so it's hitting them a little slower than kind of pushing all 50 at one time. If your patient does have a drop in pulse ox because of the pain medication, we don't want to just go pushing Narcan. As long as their respirations are adequate, and it's not uncommon for them to drop down to like 90, 89 after getting fentanyl, we can put a nasal cannula on that patient to get them above 94, but we don't want to just go reverse the pain medication because then they can't receive any pain medication. With an abdominal evisceration, this is when your internal organs are going to leak out through some kind of break in the skin to the external part of the body, and typically it's going to be our intestines. I have seen some small eviscerations with stabbings to the abdomen and gunshots to the abdomen because we've created that open space for that intestine to kind of loop to poke through. I've never seen one this bad, but I have seen just a little loop of bowel sticking out of a gunshot wound to the abdomen. It's actually not too uncommon if we have a penetrating injury to the abdomen. This is obviously a little more serious, a little pronounced. I did want to show you, I like this picture because it shows that mesentery I was talking about, that kind of fatty fold that suspends those intestines. So that's what that yellow thing is. That's the mesentery, and it kind of holds the small intestines in place. But if we do have an evisceration, whether it's big or small, the way we treat it is we're going to cover this with saline-soaked sterile gauze. So just take some of your sterile dressings, and then I just take a saline bag and I'll cut off the end, or I'll take some flushes depending on how big the dressing I'm using is, and kind of soak that dressing and place it over the eviscerated organ. It has to be moist, and usually we use dry dressings, but with this one it has to be moist because we're putting it on an organ surface. And that, remember, our internal organs like that nice, moist kind of environment. Now, if we do have some warmed saline, I would definitely go with your warmed saline over using cold saline, because cold saline directly on an internal organ could be quite a bit of shock to the system. So moist, sterile dressing over the evisceration, and then we want to put occlusive dressing over that. So the ones I've had are pretty small, so I was just able to take like a 4x4, put some saline over that, put it over the loop of bowel sticking out, and then those big Tegaderm dressings, they look like Tegaderms, but they're, quite a few times bigger. Put that over it to create an occlusive dressing. Obviously, it would be a little harder with this one. This one's quite big. So to make a bigger occlusive dressing, you could actually use an IV bag. The inside of the IV bag is sterile, so you could cut apart an IV bag and put the inside of the IV bag over the moist dressing, so it's as sterile as possible. But that one would be kind of hard to dress. Big no-nos that we don't want to do. We don't want to try to put the organ back into the body. So that is going to be your biggest no-no. If you do have a patient that does have an evisceration, they're probably not going to want to lay flat on your cot. So as long as they don't have a C-spine injury, we're going to definitely let them lay in whatever position of comfort. And the reason being is when they lay supine, it's going to stretch that abdominal wall, and it can actually strangle off the bowel that's sticking out by tightening down on it. So they kind of want to go in the fetal position to kind of loosen up that abdominal wall as much as they can, because it's going to, help with pain a little bit. Obviously, this patient's going to be a really good candidate for some fentanyl, 50 to 100 micrograms, because we want to make sure that we make them as comfortable as possible, because obviously this is going to be really, really painful. So with our penetrating injuries, we talked about most of the time it's usually a gunshot or a stab wound, which typically doesn't leave us with an impaled object, or if we have an impaled knife, it's usually not as bulky or bad to transport. We do leave it in place, but it's not going to cause concern like this, where we have a giant piece of rebar or something sticking through our patient. So that's going to be obviously a little bit more complicated. So if we do have an impaled object, we do want to leave it in place. If it's something smaller, like a knife handle sticking out, pretty easy to stabilize that. We're just going to get a little creative, put some bulky gauze around that, bulky dressing, and a lot of tape, just trying to make sure that it's not going to move. But if we have something like a long object like this, we may have to get a little creative and definitely get some help from our fire friends to maybe even cut this down. We don't want to cut it if at all possible, but in some situations, like with this patient, we would have a hard time flying this patient because this is just way too long to fit in a confined space. So we would have to probably trim that down. It's dangerous to trim these down because it causes movement, which can cause more internal damage. And if it's metal and we're using a saw to cut it, can also cause heating of that object and cause more burning damage. So definitely work with your fire department. They are great at knowing how to cut a lot of these things down. That's what they're there for, to help us, but we're going to try not to cut it if we don't have to. We're just going to try to stabilize it in place. Big no-no with this is never remove the object, because this could actually be tamponading off some bleeding through some major vessels. So once we remove that, we're going to kind of a free pathway for a lot of bleeding to happen. So we want to leave the object in place unless it is blocking the airway or is hindering us from doing CPR in the event of a cardiac arrest. So for example, I've had a patient who had a knife sticking right out of his sternum. He was actually pretty stable. He was walking around. Knife was still in the sternum. We just bulky dressing to that, left it in place. The only reason I would have taken that out is if he had coded, so I could remove it to start CPR, and that would be the only reason to move that at all. Right, now we're just going to kind of briefly cover each organ and things that could happen if we have trauma to these organs. So first one we're going to talk about is the liver. Liver is the most commonly involved solid organ in penetrating trauma. It is very vascular, very, very rich blood supply. So we have the hepatic artery, which brings blood to the liver, and then we have the portal vein, which brings deoxygenated blood away from the liver. And we worry about, getting bleeding because they're very, very rich in blood supply. We could lose a lot of blood through these arteries and vein. I do want to point out this here, this ligament. We're going to talk about that on the next slide, so just keep in mind where that ligament is. We also have the gallbladder under the liver. The gallbladder is well protected by the liver. The gallbladder typically does not get some trauma to it because it's protected by the liver, so that's a good thing. But look how much space this takes up in the abdomen, so that's why it's the most commonly injured solid organ when it comes to penetrating trauma, mostly because just the space it takes up. It is partially protected by the rib cage. We'll come down and cover some of the top portion of this liver, but there is some that is exposed. So with liver injuries, it is the most common largest vascular organ in the abdomen and most common injured with penetrating trauma. So also want to keep in mind any right-sided injuries. So if we have a patient who was a passenger in a vehicle and they were T-boned on the passenger side, I would be worrying about some possibly liver lacerations or injuries. And where we look for is that ligament that I talked about. That's that ligament here. So right here, this is its point of attachment to the abdomen, and this is where we're going to get the most tearing occurring, because that ligament is going to remain in place and the liver may move in those deceleration injuries. So if we're going to get some liver lacerations or tears, typically it's going to be in that area where the point of attachment is. Some injuries that might present with this. So if we have any right-sided abdominal injuries, we should be thinking about the liver. Any right lower rib fractures, those ribs could actually break off and puncture the liver as well. Any bruising over the right upper quadrant, and any guarding or rebound tenderness. And then also we want to look for that hypotension and hypovolemic shock. Because of how vascular it is, the patient is very, very prone to hemorrhage, internal hemorrhage. Next for our solid organs is our spleen, and although spleen looks very, very tiny on here, it's also very, very vascular, and it's kind of squishy. It's made of that reticular tissue, so it's not very strong tissue. This is in the upper left quadrant of our abdomen. So we know the spleen helps with filtering our blood and getting out old, red blood cells. It's part of the immune system, part of the lymphatic system, but it does filter about 5% of our circulating blood every minute. So there's a lot of blood going through the spleen at any given time. So if we rupture that organ, we can have some major, major bleeding. How they fix this is they'll actually go in and take the spleen out, because we don't need a spleen to live. But if we have that open pathway of bleeding, we're going to lose 5% of our circulating blood potentially every minute. So it can be very, very life-threatening to have a splenic injury. Our spleen, because it's located in the left upper quadrant. So we talked about that truck accident earlier that I showed a picture of. I would definitely be worried about spleen in that picture. If I'm thinking of, in terms of abdominal organs, I imagine that patient had a ton of injuries because that was pretty heavy damage. But with hitting that left side, I always think about spleen. So for my drivers who get hit on the driver's side, that's something I'm always kind of thinking in the back of my mind. They might have some left shoulder pain that's called Kerr sign, and that's referred pain that we get with splenic injuries. So any trauma to the left-hand side or the left upper quadrant, any rib fractures in the left lower ribs, if the patient has that unexplained hypovolemic shock or unexplained hypotension. And then again, also that pain to the left shoulder, that's Kerr sign. Right, next is the pancreas. Luckily, the pancreas is kind of sits further back in our abdomen, so it's very well protected by the liver and stomach. And remember what our pancreas does is it does secrete the hormone insulin, but it also secretes digestive enzymes. Remember, it's an endocrine and an exocrine. So its exocrine functions is secreting those digestive enzymes. So that's really important to remember. So when we get an injury to the pancreas, and luckily this is a little less common because it's so well protected back towards that retroperitoneal space behind the liver and behind the stomach, it takes a really high energy force to damage that pancreas. However, if we do get a pancreas injury and that pancreas starts leaking some of those digestive enzymes into the peritoneum or the surrounding tissue, those digestive enzymes will actually start to break down other internal organs and other tissues that it comes in contact with. We call that autodigestion. So basically your pancreas, those pancreatic enzymes are going to start digesting your internal organs. So this is extremely bad. There's definitely nothing good that comes out of that. It's going to be very painful for the patient, and they're going to have a ton of complications, definitely going to be rushed to surgery as soon as possible. For our small and large intestines, they kind of group these together. It's more common that we would get a small intestinal injury because our small intestines lie right in the middle of our abdomen and cover that whole anterior surface. But with these, we worry about getting openings and rupture of the intestinal spillage out into the abdominal wall and out into that peritoneum. So we can see here we have some trauma here where the patient may have been stabbed and it actually went through. We can see here it went through that small intestine. So we're going to get those partially digested foods leaked out into the peritoneum. So it's not necessarily bleeding with this one. Bleeding is more common concern of our solid organs. With our hollow organs, it's that spillage of digested material causing that peritonitis. So they're going to get that chemical peritonitis. Very, very painful. They'll have that broad, board-like abdomen, extreme pain for that patient. And we really, really worry about infection long-term with this, because this patient could easily become septic and get that bacterial infection very, very quickly, because our digestive food isn't necessarily sterile. So it's not good that we have that come in contact, especially all the bacteria that lies in our intestinal flora. We don't want that getting out of there into the abdominal cavity. And then last, we have the stomach. So we see the stomach here. It is a hollow organ. It's mostly in the left upper quadrant, but it is a little bit in the center as well. And this is just a little storage area for food before it goes into our small intestine. Stomach injuries are more common from penetrating trauma than blunt trauma. Reason being is we have a little more give with our hollow organs, remember, so it's usually penetrating trauma that's going to cause injury there. And if we do have a rupture, it depends on how full our stomach is. So the more full our stomach is, the more likely it is to rupture, because it's going to have less give. If my stomach's empty, I got a lot of room for wiggle there. But if it's full with contents, it's going to be easily ruptured. So it really kind of depends on really the last time you ate and when this injury occurred as to how serious it could be. And again, what we would have there is not only with our stomach, we're going to get that spillage of, food particles, but we're also going to get acidic material because we have all that stomach acid. So that's definitely going to cause some peritoneal, that peritonitis, that chemical peritonitis pretty immediately as soon as it comes in contact with that peritoneum. As far as the vascular injuries, we do have our inferior vena cava and we have our descending aorta. And then off the aorta, we have branches that supply all of the abdominal organs. And then branching off the inferior vena cava, we have those venous, those veins running from the organ to the inferior vena cava. So a lot of really big vasculature down there, and most commonly going to be hurt with penetrating injuries in these instances. Most of that lies towards the retroperitoneal area, so it's kind of back further. It's very well protected. So that's why it kind of takes a penetrating trauma to really cause injury to these great vessels. If we do have tearing or shearing or lacerating of these vessels, if it's your inferior vena cava or your aorta, you will most likely exsanguinate pretty quickly, especially with your aorta. It also depends on how big the tear is. If it's a very tiny tear, it might be something where you have longer and you could potentially go to surgery and have that fixed. But again, you probably should be, hopefully close to a trauma center for that to happen. Some of these smaller arteries that, branch off and feed the kidney or the small intestines, you have a little bit longer to get to surgery, so your outcome is going to be a little bit better. But this could also still be very, very serious and life-threatening. And that's the patient I had where I talked about his belly, that young male whose belly was kind of getting really distended and he looked pregnant. By the time we were loading him into a helicopter, he had one of those smaller artery vessels, like off the kidney or something like that, tear. And just that small artery was causing all of that bleeding. So these are typically very, very bad injuries. Right, when we go down to the genitourinary system, we have our kidneys. Our kidneys are our most vascular organs of the genitourinary system. They lie in the retroperitoneal space, just at the end of the rib cage in the back. So it actually sits up a little higher than we think. The kidneys are going to filter all of our waste product out of our blood and make urine. That urine goes down the ureters into the bladder. So when we get retroperitoneal injuries, this can include the pancreas, also includes the kidneys, some of those big vascular structures, and then part of the intestine. Typically, we don't get that peritonitis because we're going to be back further. We're going to be more posterior in that separate cavity. So what we want to look for is any ecchymosis, so we can look for signs of bleeding that way. We have colon sign, which is bleeding around the belly button. We see this with some intra-abdominal bleeding. I've seen this with pancreas and bleeding, trauma to the pancreas. And then we have gray Turner sign, which is bruising or ecchymosis at the flanks. So the back side of where your kidney is located. And this would be indicative of a retroperitoneal hemorrhage, probably the kidney, because it's one of the more vascular organs back there. So gray Turner sign, ecchymosis of the flanks, colon sign, ecchymosis of the umbilicus, both signs of internal bleeding. And again, this may take some time to show up, so that's why reassessment is so important, because we may see this before we get to the hospital, but it's not something we may see right away. Most common cause of kidney injuries are actually going to be sports injuries. So we see it a lot in football injuries. I've seen it in soccer injuries. Kidney punches was what they call them. So just getting that direct blunt trauma right to the back there. So contact sports is going to be our most common cause of renal injury. We could also see it in some high-speed motor vehicle accidents or maybe some falls from heights, depending on how they landed. Also, if we have some broken ribs in the posterior, in the backside, I would worry about kidney as well. So ruptured kidneys, we're going to get a lot of flank pain. Going to be kind of similar to a kidney stone in location, but it's probably going to be more dull and achy pain and not so much the sharp pain. They could have pain on inspiration because we're going to have that increase of pressure in the chest. It's going to kind of push down on it. But one of the most prominent signs that would lead me to kidney injury would be hematuria. And gross hematuria just means a lot of blood in the urine. So we would get a lot of blood in the urine. Again, not something we might see pre-hospitally, but I have seen some bloody urine on patients who are unresponsive, who had voided themselves, and we go to remove their clothes and we notice that blood in the urine. So it's going to kind of put light bulbs off in my head that they could have a really significant kidney injury. Ureter injuries are probably not something we're going to be picking up on. Typically aren't immediately life-threatening, but definitely something that needs to go in and have surgical intervention. We could get some shearing or tearing if we had a rapid deceleration injury, but again, not commonly injured and not as life-threatening, and we would probably see some blood in the urine or lack of urine. With our bladder injury, it's actually going to depend on how full that bladder was. So the more full the bladder was, the more likely it is to rupture. If the bladder's empty, it's very unlikely to rupture. So it really depends on how full the bladder is. But this would have to be associated with some other significant injuries, because if we look at where the bladder's located, it's actually pretty well protected by the pelvis. So if I had maybe a pelvis fracture, some pretty significant lower abdominal injuries, I could possibly have this bladder rupture. Bladder rupture is actually very deadly because all of that urine is going to leak out and damage other organs. So this is actually pretty bad. And this CT here shows the white area here is a bladder. And obviously this bladder was very full because it's all that white is going to be urine. And it looks like here, that black spot, there was some type of rupture there. And we could see that urine leaking out into the abdominal contents, which is pretty bad because it's going to go ahead and damage all of those other organs. Not too much that we can do with that bladder injury. We're just going to get them to the level 1 trauma center as soon as possible, monitor for shock, things like that. But unfortunately, there's not too much pre-hospitally that we can do for a lot of these abdominal injuries. Right, when it goes down to the male genitalia, our biggest concern is going to be loss of fertility. So our younger males who would be of that age, obviously if I have a 70-year-old, I'm not too worried about the fertility, though males do remain fertile for a very long time. So it's something that we do want to think about. Typically it's going to be blunt trauma. We see a lot of these in physical assaults and sports injuries. Don't see too many genitalia injuries in motor vehicle crashes, more likely to be in a motorcycle accident than a motor vehicle. We could also see this in penetrating trauma. So we have had stabbings, gunshots, or even animal bites in that area. For our penis injuries, it is something that is really something that we need to take seriously. There is an artery there. And It could be blunt or penetrating trauma depending on the type of assault that was taking place. So there are some other reasons for priapism other than a spinal injury. So sickle cell disease can cause priapism, and also adverse medication. So something to keep in mind. For penetrating trauma, usually it's going to be gunshot wounds. And that's not only from assaults, but also a lot of males keep their gun in their belt, and it accidentally goes off and they get shot in the groin. As far as the foreigner gangrene, I'm not really going to go over that too much. That's typically something, a bacterial infection that takes a long time to result. But just to point out that if we do have any like lacerations or breaking of the skin in that area, it is important to be seen by a physician, even if it's the patient drives himself, because it is a really high area of bacteria. So it's a really high risk for infection in that area. So they need to go get that taken care of. Patient may be embarrassed and they don't want to go to the hospital. So we just kind of need to educate them and say, you may not want to go to the hospital, but you need to at least drive yourself, because that really needs to be cleaned out correctly so you don't get a bacterial infection. If you have an amputated penis, yes, this has happened to me, would be very rare, but keep in mind there's an artery there, so you're going to have a ton of bleeding. In the situation I was in, the patient was actually, this was when bath salts were really big, so the patient got high on bath salts and he actually cut off his own penis, completely off, and then the police had found him and he went running from the police because he was scared. But because there's an artery there, he actually passed out from blood loss pretty quickly. So he was pretty hypovolemic when I got there, pale, cold, diaphoretic, weak throaty pulse. So I was more worried about bleeding than anything else, and just holding pressure on that, trying to get bleeding to stop, giving some fluid resuscitation. With any amputated part, you should try to recover that amputated part, so do keep that in mind. For our female genitalia, typically we don't see as much trauma to the female genitalia because it's not external. So more males are more common with that type of trauma because it's more external. But some things that we do want to keep in mind can be motor vehicle crashes. We have seen some uterine injuries, especially if the patient's pregnant. Definitely something that we want to find out. And we have seen some stabbings, unfortunately, gunshot wounds to the uterine area as well. So unfortunately, those things do happen, and those are highly vascular areas, but we're going to talk about OBGYN coming up soon. We do want to, signs that we would have trauma to that area. Probably the biggest sign is going to be bleeding from the vagina. Probably going to be self-reported by the patient, but if the patient's unresponsive, I have found things like blood in the underwear from trauma, and it means we could have some type of internal lower pelvic traumatic injury, which is very concerning because it is a very vascular region for our females. Also, be aware of the possibility of sexual assault and kind of what to do for sexual assault with your protocol. So if there's an external hemorrhage, meaning, it's not coming from any internal organ, so they maybe have a stab wound to the uterus or something along those lines, we're just going to treat that like any other external hemorrhage by putting pressure on it, administering fluids if we have to. If this is something along the lines of sexual assault, we do want to make sure that we are following our proper protocol. Here in Lorain County, we actually do have the Nord Center that will do rape kits on our patients. So sometimes I've taken the patient directly to Nord Center if that's what they're going for. But if they have any other injuries, they need to be medically cleared before they go there. So you may be going to a hospital more likely before that patient goes to the Nord Center for that treatment. If there's any objects internally, we're not going to remove those, and we're not going to pack the vagina for any reason at all either. So we're just going to kind of leave any object that's in there, and we're not going to pack it if we do have bleeding.